day, everybody, and welcome to our webinar today. I'm Denis Gagné, CEO and CTO of Trisatech, and I will be your host. And with me, I have Dr. John Svirbily, Trisatech CMIO. Today's topic is AI agents you can actually trust in healthcare, basically going from opaque to actual governed automation.
Thank you, Denny.
Thank you,
Denny. The recording of the webinar will be available after the webinar is complete, so it'll be available if you want to come back to it. Okay, so let's jump right in. And I think everyone agrees that artificial intelligence is absolutely amazing and has great capabilities. However, when it comes to healthcare, it doesn't really succeed as much as one would hope. And I think one of the reasons that this comes into is that although AI is valuable, it has to be something people and patients can trust. Because people have problems with some of the trust aspects, this is the reasons why aspects have failed. And so the barrier isn't capability, it's reliability and governance. Next slide, please.
Yeah, so fundamentally what you're saying is that in the healthcare context, trust is very, very important. And that trust is built by making sure that everything is governed and not just acting ad hocly.
Right. And I mean, it's similar actually to any asset, whereas an asset can be very valuable, but what you get for it is only how much someone is willing to pay for it, how much demand they have for it. And I think that's what we want to do, is bring the two in sync so they do reflect each other. And when we look at the problems that AI faces, there's actually three perspectives that we would like to introduce. The first is the clinician. And well, the problem with AI, anyone who's actually read the disclaimer, is many of them say this is for trial only or for amusement, and no one in the right mind would use it for anything serious. So when a clinician tries to use AI in healthcare, the AI is not going to be held responsible for it. You are. Anything that happens, your name is on the chart. You're the one the lawyers are going to call. And you're there. Recommendations are coming out that you may not have made. And you're getting recommendations which are somewhat opaque, and you don't really see how it was reached. And some of the additional problems are listed there. But in the end, clinicians may feel they're left holding the bag. Next slide, please. The next group is the informatician. And the informatician faces two main problems. One, there really is, there's no perceived control over the decision logic, and there is no audit trail. And if you're trying to justify a decision, or if you're trying to meet regulatory compliance, where the demands are for good manufacturing practices, all the fundamental features of policies, procedures, data testing, audit trails, none of this stuff is available. It can be very hard to demonstrate. And so the informatician may be left unsatisfied with what they're given a task to provide, and they can't provide it. And then if we go to the third group of people that are affected, we have the architect. And the architect is faced with a black box in many ways. And it's worse than just your basic black box, where in electrical engineering, if you have a black box, you give a certain input, you expect the same output. With AI, you get you may make a change, and you don't know what exactly you're getting out. So it's the worst possible black box that you can get. And so the AI logic is hidden in prompts. There's no deterministic control. There's no a chance for orchestration, and there might be tight coupling. The logic gets fragmented as you go across systems. Next slide, please.
So basically, the clinicians have the accountability the informaticians want to make sure that what they provide to the clinicians are explainable and according to evidence of clinical value. And the architects have the problem of integrating this into an overall system architecture and need to be able to ensure governance of that components as they added it. Is that a good summary of what you said,
Yes.
John?
Well put. And so basically, we've mentioned 3 different audiences, and each has their own different pain. When you really look at it, there's really one root cause, and that is that the AI is not really properly governed. Behavior can be unpredictable, logic may be hidden, or you don't even know what's going on, and prompts and code really don't give you much insight. Overall governance is impossible, and that's not something that you really want in a clinical system where patient lives are on the line. It's difficult to establish trust because you can't, if a person has questions, you can't give a good answer. And so this results in concerns when it comes to clinical adoption. Next slide, please.
Yeah, so fundamentally, the problem is not necessarily the AI you're using, but the problem is the harnessing and the architecture that's around it to allow you to do what you want with all the behavior you want.
Right. And oftentimes people will give AI a very broad request that might involve multiple tasks or multiple decisions that need to be made. And it's very hard to separate them out into more digestible fragments, which poses problems. So the solution really isn't by hoping that AI will get better, because it already has limitations. What we want to do is come up with something that is a better solution, and that solution already exists. And that solution is that you want to build an architecture around the AI so that it makes it both that the AI becomes stateless and replaceable. The key principles of this approach is that you use modeling of the workflow, you use modeling of decisions, the AI is used to provide data, and the final outcomes become deterministic. And the tools that will be using the standards of DMN, BPMN, and CMMN as the main framework for this.
So the idea is to use existing standards, open standard that exists to capture your workflow, your decision in your case, using the object management group standards, BPMN, CMMN, and DMN, capturing how things should be done, which ensure us that they're done in the same way all the time, but leveraging the AI as a stateless entity within this so that we always get the best of both worlds.
Right. These tools provide the governance that we believe is necessary. So what does governed architecture give you? It depends if you're a clinician, informatician, or architect, but for each one, the governed architecture solves many of the problems that we've mentioned. For the clinician, the AI that explains recommendation and follows the protocols, so the accountability is supported. For the informatician, the logic can be versioned and audited, so everything can be properly tracked according to what the informatician needs. And then for the architect, they have a portable deterministic plane where the AI can be is more or less constrained, and then the decision, the process and decisions are embodied within the models. Okay, the governing principles is decisions are externalized in versions. The AI is used as data that is then used by the models. And when you use this, you can evolve the clinical policies without a massive need to rewrite code, which is a real benefit in many organizations. Next slide, please.
So I think what's important here is that second line is that we use the AI and we treat what the AI provides us as data, just more data in the context of the decision, more data in the context of the process, the case management. And the AI is not actually providing the outcome, it's just feeding into an already structured and governed environment.
And also, you can take the request for AI, which might have multiple things that need to be done, and break it up and distribute it as services throughout the models. So it's far more controllable and digestible, and you can really judge each step. You're not making huge leaps. You're making very careful steps that you can check the quality at each point. And in many ways, what you end up is with a team approach towards handling the healthcare. Handling the software. Just like in healthcare, you might have a team. Here we collect a team of tools that help us go through each point, and when taken in together, we get the solution that can be individualized for the patient. So orchestration is handled by BPMN standard. Decisions are handled by DMN. CMMN handles discretion and case handling. The AI is very good for understanding natural language and understanding context. And then FHIR provides the data through interoperability. So with all these points handling together, all the benefits can be achieved without the downsides.
Yes,
Next slide.
In passing, I want to mention also the HL7 BPM community of practice, which is an open community anybody can join, where we're exploring how to leverage all these languages, the BPM plus language, including BPMN, CMMN, and DMN, and leverage these within an HL7 context of FHIR, CDS hook, Smart on FHIR, and AI. And all these different pieces are brought together to give us the best possible architecture for a solution.
Yes. So when you have governance, you can have a versioning of models, you can have a proper control, you can do auditing and tracing and testing, which is all recorded. You can see who made what decisions when, which all has a benefit when it comes time to explainability. Policy changes do not require code redeployment, and every AI invocation is treated as data, which is then controlled in the process. Next slide, please. As far as EHR and FHIR, both are essential for clinical practice. Both of those are integrated with the current modeling softwares. And so it allows you to embed the models in the current workflow. It allows transportability between EHRs. Everything is standards-based. There's no hidden logic layer. And you can get independent versioning of the workflow and decisions, which can be adapted to each institution. Next slide, please. And so you end up with different control layers, where the AI services are at one layer, but you have a decision layer, an orchestration layer, which can actually oversee the overall operations. The decisions that are made are integrated with the EHR and with FHIR. And then the presentation layer is what is shown to the actual user. So all these services in a layered approach can give you a final product which is quite robust and meets all the regulatory requirements. And all of this work is not only is it feasible, it's also been demonstrated. And TriSotech presented this last year at HL7, won a reward for showing that clinical pathways and decisions can be used both by clinicians to access AI agents. And I believe that takes us up to the demo. Back to you, Danny.
Okay. So let me try to demo some of those concepts for people. what I'm showing you now, this is an actual clinical pathway, a simple clinical pathway. I capture using the BPMN standard, so the business process model annotation. It's a simple anemia example. Uh, it's small enough that it shows things in a simple, easy way to grasp, and it has enough complexity to show the possibilities. So the first thing that's done is that there's a grading of anemia that is done based on the World Health Organization anemia grading guideline. If there's no anemia present, then we're done. If there is some anemia, then I'll go pull MCV and RDW data from the patient to come up with a list of potential anemia present. So this actual process calls upon some decision. Here I'm calling the anemia decision, which is mapped in. So this decision is based on the World Health Organization guideline. It brings all the rules and all the knowledge into one decision. So for example, this is actually based on my evidence here, which is an actual guideline from the World Health Organization. So this is the evidence used in creating this logic. So we have evidence-based logic. This is captured and coded in here in a visual, easy to understand format from the clinician, a decision table. So each row is a rule. So the first row says, according to the World Health Organization, if you're between the age of 0.5 and 5, we don't really care about your sex. If your hemoglobin is more or equal to 11, then the World Health Organization says that there is no severity, and you can see all the different rules for female non-pregnant, female pregnant, and male, and we can easily add more rules as needed in here, which I won't do to mess up anything in there. So this logic is all captured and becomes deterministic. So it's visually easy for clinician and informatician to validate and map into the standard, but it also gives you that it will always give you the same results every time. So we can deploy this particular service, and now we have a REST implementation of that service. So I have a fully documented REST API of that service. So right now, not much AI involved. We're right into capturing in a deterministic way the clinical logic. And we can, surface a form that allows you to embed it, and then you provide your patient name and all this. So what we have now, the tool also generates for you a capability of chatting with that logic. So that's where we start involving AI locally. So now I have the possibility of chatting with that model, and I can say, assess the anemia of Mary Reed. And so what's really happening now is I'm using the flexibility of generative AI and probabilistic AI to understand the context of the conversation, what is being asked, and then the AI calls the tool that I just showed you that runs in a deterministic way. So here you see the AI is answering me back about Mary Reed's results and what they are. And then I can just say, what about her husband and Price? And now that's where we show the flexibility of the AI. So the AI understood very easily that I was still asking about anemia. I didn't have to say, what about assess the anemia? I just said, what about her husband, Andrew Reed? And it says, well, in the case, Andrew doesn't have any anemia. And I can even be more abstract and just say, Andrew Garnier. And then again, the generative and probabilistic AI is able to understand that those are all questions related to anemia. So it's adapting to the context and to the question. And in the case of Denis Gagné, it says, well, I don't have any knowledge of that patient. And what's really important here is that the way it's done is that none of the healthcare personal information, the PHI, the personal healthcare information, is transferred to the AI. The only thing that the AI have access to is the tooling, and through the tooling behind the firewall, this is accessing the PHI and only returning the results. Now, the strength of this approach is that here I'm using it within the TriZetech environment and using the chat with the model, but I can also go into another AI platform. So if I go into Copilot, let me just refresh this. For some reason, it went blank on me. It's always slower when you're sharing screen.
It hasn't had its coffee this morning.
Yes. So, okay. So now I'm in the Microsoft Azure Copilot environment. If I go and look at the agents here, if this can refresh. I can take the TriZetech helper here. And sorry about the slow responsiveness. That's part of doing a demo, I guess. So now I have my agent that has the same tooling as we had. So I can ask the same question, assess the anemia of Mary Reed. I keep hitting the chat button. And here we'll see more details, and you see what the AI is actually doing. It knows that it's got to call that initial anemia MCP, which is that model that I was showing you and all the dependency. And you can see that it's providing me with the same results as what I was getting within the TriZetech environment. I'm sorry, here when I was using it in the chat. So I get exactly the same result here. And then I can go on again. Do you know about her husband, Andrew Price? And again, the AI as telling me that it doesn't have any specific information. So what about his anemia level? So now it knows, and it's going to call the same thing. It knows that I was still talking about Andrew Price, and therefore knows that it's in the context. So again, each AI model will have a different behavior in terms of extracting the context, but will always go back to the deterministic model to do the clinical portion of this. And then I say, let's say I go back and I say, assess anemia Denis Gagné. Then it comes back and it says, there's no record of a patient named Denis Gagné. So it's basically saying, within this system, we don't know of that patient. There's no information about that patient. So fundamentally here, you can see that what we're doing is we're providing very flexible AI context, probabilistic generative AI model that are able to extract the context, extract what is the intent of the person that it's interacting with, and then based on that intent, we'll call the right tool to always give you the same results, healthcare results, no matter which AI you're using to call it from. So it's giving you that kind of governed environment that is what you always want when you're dealing with AI.
And I think one nice thing about it is, because you mentioned the context, is for many algorithms in healthcare, there may be different ones for different ages, races, sex, whatever you've got. There may be different ones. And then based upon the context, you can choose not just one, you can choose the best one for the patient's characteristics. And that's a great, that's a wonderful level of flexibility.
Yes.
Okay, so the key takeaways is that we not relying on the AI by itself, but we want to govern the architecture around the AI to solve some of the problems that users of AI face. And so for the clinician, they have confidence that the AI behavior is explicit, audible, and overridable. For the informatician, the governance model can be versioned, traceable, audited, and tested. And then for the architect, we have the bounded AI with deterministic control plane that again can be tested, audited, and governed without any sense of a black box. And so this is how clinical AI can be scaled safely and to avoid black box risk.
Yeah, so fundamentally, the clinicians have the ability to deal with the workflow and the decision that are very obvious and clear. And so they know that this is what's happening. These are the rules that are used, which are rules that are based on clinical evidence, and that it's always going to give them the same results. The informatician can make sure that these rules and these models are versioned and always provide you a trace of the execution. And from an architect point of view, you can separate these different patterns using technology that's been well proven in many industries, and still leverage the power of what AI is giving us today. And that power keeps on growing and growing. Week after week, months after months, we've seen AI grow in its availability and capability. So we want to be in a situation where we're always in a state where we can benefit from that. So we use at TriZetech, we use the principle of bring your own AI and bring your own agent. So you can have tools based on AI that you can use in context, or that you have agents that are acting within a very strict context, which is the same context that human would execute in within a process or a case or a decision.
And people sometimes don't adapt well to rapid change, but this approach allows you, as the new AI tools come out, you can adapt, you can choose the best tool to meet your need, which gives you the greatest flexibility.
So I've seen quite a few questions going by. We can address a couple. We have a few minutes left. So yes, so the first question is whether the recording will be available. Yes, both the slides and the recording will be available really soon on the TriZetech website. Somebody else says, nice presentation and approximation. This can go further in understanding that AI tool is just a lever of Industry 4.0. The key is to understand that we are modeling a digital twin. Yeah, and in effect, you can make that argument. And let me see if there's a question there. Disallow control, but not only AI, but for other lever cobots. Yeah, so the person is just agreeing with the points we're putting forward. Let me see, I can see. Building trust involves demonstrating how AI reduces the administrative burden on the clinician, allowing them to prioritize patient. Oh yes, we certainly agree with that. And that trust needs to exist for them to accept that alleviation of burden. So clinician, and John, you may want to talk a little bit more about that, but a clinician won't just accept any answers. They want to make sure that this is answers that they can go to bat with and say, I'm going to be accountable for that answer.
Well, I think not only is it, and there's the liability concern, is that you're being asked to do something for which you really don't understand what's going on. The other is most clinicians are concerned about the patient. And how can you possibly recommend that a patient get a care that you don't understand yourself? So I think on multiple layers, clinicians want demand and want trust, just like they're trusted.
And with that, we're going to stop now. We're completed on our time. If you have a question, feel free to reach out to either myself or John. Our emails are there. The slide and recording will be available on the TriZetech website. Thank you very much for your participation. We hope this was a little bit insightful, and we'd be happy to discuss any aspect of this with anyone that's interested in continuing the conversation. Have a
Thanks
great
very
day.
much.
Okay, bye now.
Take care. Bye-bye.